Alright, so today is going to be your last actually recorded lecture, I believe, yeah, for this class, because this is for Monday, which is July 13th. This is your lecture for July 13th, and then we'll do a live one on the 16th, and then your final will be on July 20th. All of a sudden, everything's wrapping up. Alright, so blood pressure. We're moving on here. Fairly short lecture. So when we're talking about blood pressure, we're basically talking about pressure generated by your actual blood. Okay, so as you can expect, we have the highest, obviously, in our arteries, that coming off the heart, off of our pump, and the lowest in the veins. So that gradient then between the veins and the artery then, or the contraction, so your systolic or your diastolic, your relaxation there, that pressure gradient is then what determines your blood pressure. So the difference between the beginning and then the ending pressure basically within a circuit. So we want to make sure that we have a sufficient pressure to help, to pump our blood, so we maintain that cardiac output so we can get the blood and the oxygen and nutrients through all parts of our body. So this force then is applied to our artery walls, our arterial walls, and again the pressure is highest in the arteries and lowest in the veins. So the maximum pressure then is you're thinking about the ventricles contracting, your systolic pressure where you have that squeeze, okay, and then the lower pressure because you still have some blood pressure in your arteries during that relaxation part, or your diastolic pressure. Okay, so that's the lower pressure. Alright, so when we refer to different terms such as hypertension, okay, hypertension then is obviously an increase, okay, hyper being high, an increase in your arterial pressure. And we want to avoid that because it can lead to ruptured vessels and then a stroke. Also, we want to avoid too much of a hypotension because then we're not going to have enough to sustain life. We'll have loss of circulation, seen mainly in like massive hemorrhages, traumas, sepsis, and we're going to talk more about that here coming up. And some of the things that you would consider treating hypotension with. So when you think of hypotension, you just think of kind of like low volume. Okay? So your pump is not getting enough volume, enough fluid. So one of the things that we can treat it with are red blood cells, so you get packed cells. Albumin is a big volume expander, or saline, other types of solutions, or like a glucose solution. Alright, so we are going to talk about some different factors and that can affect your blood pressure. So obviously your blood volume, that is definitely related to your blood pressure. Okay, so it's a direct cause of your blood pressure. So some of the things that can affect your volume, so when you're thinking of if you have increased blood, okay, so for some reason you're fluid overloaded, you have increased volume, your blood pressure is going to be high. And if you have low blood in the vessels, then your blood pressure is going to be low. So that should make sense, right? So hold on one second, I just want to double check something. Okay, I hate that I can't go back on these slides without messing it up, so I just wanted to check something before I start talking way too much, because I wanted to see if I'm talking more about this on the next slide. But anyway, so blood volume. So some of the causes, if you think about things that would make you kind of dry or like a lower blood volume, would be dehydration. Okay. So you could have a lower blood volume due to dehydration. Pregnancy can actually, increase your blood volume during pregnancy. So a lot of women then have trouble with hypertension. So if you think about kind of the distribution of the blood, and I think this is kind of interesting. So if we have normally like 5 liters in our blood, just to kind of see like kind of where is it all at every time during the cycle, kind of like where it's all distributed. So about 75% of it is in the systemic circulation. Okay, so that, you know, other than the heart. 15% then is actually in the heart, so your pulmonary circulation, or rather your coronary circulation, and then 10% is in your pulmonary circulation. So that's kind of how it's kind of divided up. So you got about 75% systemically. So just kind of thinking like where is all the blood located, all that 5 liters. So most of it is systemic. 15% about is in the coronary, and then 10% is in the pulmonary. And then of course as we age, our blood pressure can definitely vary, also with sex and with being gender, or your body size. So then the other thing that can affect your blood pressure is the force of the contraction. So how strong is the contraction of the heart? So this affects your cardiac output, which is directly then related to your blood pressure. So remember a kind of a quick review of what equals your cardiac output. So when you think of the force of contraction, I'm hoping that you're thinking of stroke volume, okay? And then your heart rate makes up the other part of it, okay? So when this says here affects cardiac output directly, unless there is a noted decrease in blood volume, okay? So I'll talk about that here in just a second. So when we're talking about this, because it just kind of depends on what's going on. Obviously, one of the ways our body compensates for a decreased stroke volumes to help maintain that cardiac output is to increase the heart rate, okay? But sometimes when you have like a really rapid shift of things, like you're bleeding, like a hemorrhage, you just don't have the fill, and then eventually your everything starts to shut down. So remembering that the stroke volume is again the volume of blood that's ejected during each contraction, okay? And then your cardiac output is the total volume of blood discharged, basically, or ejected from your ventricles per minute. And we determine that by stroke volume times heart rate equals cardiac output. So cardiac output directly influences your blood pressure, and your force of your contraction is related to that. So let's say you have an increase in your stroke volume. Okay, so you're putting out more with each squeeze, or you have an increase in your heart rate, you're going to have an increase in your blood pressure. Okay? If your stroke volume then drops, so you don't have as much coming out with each squeeze, or your heart rate is slowed down, you're also going to have a decrease in blood pressure. So decreased, again, blood volume equals decreased, and that's kind of back to the first one, decreased blood pressure, okay? But your body kind of helps compensate. Strong heartbeat is going to hopefully increase your blood pressure, and then heart rate also directly affects your cardiac output, okay? And then this is true only if the stroke volume does not decrease sharply when the heart rate increases. Okay, so we really want to make sure, that's where it can become dangerous if our heart rate goes up too high for a prolonged period of time. What's going to happen is your cardiac output is going to become compromised because you have less filling time. Okay, so you're hoping that as your heart rate beats faster, you're going to have more blood entering the aorta, which you're looking at, therefore having a blood volume and your blood pressure are decreased, but only if the stroke volume doesn't decrease, because that can happen sometimes when your heart rate goes up. Okay, that happens because the left ventricles can't fill fast enough, because it doesn't allow enough time in between the cycle, into the cardiac cycle, for it to dump into the left ventricle. Okay, and if that happens, then our blood pressure is going to drop. Okay, and that is kind of like what happens with sepsis sometimes. So the heart rate goes up, there's a fever, and then there's some fluid shifting going on, and we'll talk about that coming up today. And then you end up dropping your blood pressure. Okay, but generally, for the most part, if your heart rate goes up, and means your blood pressure is going to go up, or vice versa. Okay, but if your stroke volume goes down and your heart rate goes up, you have a less blood pressure. I hope that's not too terribly confusing. Desjardins does go over this pretty well, so refer to your chapter 5 again. And then if we look at blood viscosity, that is definitely directly related to your blood pressure, because the increased thickness increased pressure. So that makes sense, because it's thicker. If it's thinner, you have less pressure. If it's thicker, you're going to have more pressure. It's going to push more on the vessels. So patients that have become polycythemic, they have thick blood, they may have a higher blood pressure, because plus the heart has to work harder to push that blood. All right. So the heart spends actually twice as much time relaxing, basically, than contracting. Okay, so you'll hear a terminology, mean arterial blood pressure, or your MAP. Okay, if you're in an ICU or any type of monitoring area, like even the ER, they have your blood pressure is being monitored, and it doesn't need to be an invasive line to be able to calculate this. It can be, you can calculate it with an invasive line, with like a central line, but it's a calculation that the monitor is able to do. It's a logarithm where it basically, you take 2 times your systolic blood pressure plus 1 time of your diastolic, and you divide that all by 3. Okay, so so on the monitor it'll show like a systolic blood pressure and then diastolic pressure, and then it'll also refer to a MAP, or mean arterial pressure. Okay, so let's say if you had a blood pressure of 120 over 80. Okay, so 120 being your systolic, okay, plus 2 times your diastolic. So if your diastolic was 80, 2 times 80 is 160. So then you would take 120 plus 160, which gives you 380, and you would take 380 then and divide it by 3, and so you'd have a MAP of about 93, and that's a good number. If you have a mean arterial pressure of less than 60, then you are looking at compromise to the tissues. Okay, compromise to the body. So your blood pressure isn't high enough to maintain enough circulation to the vital organs. Okay, so you want to have a MAP of at least 60. And believe it or not, the first organ, the organ that's hit the hardest, is your kidneys. Okay, so you can develop renal failure if you don't have enough blood circulating. All right, so this is just kind of showing you all the different pulse points throughout the body. Let me see, I just want to make sure I'm kind of looking at a couple different sets of notes here. So we're talking about like your pulse. You're really talking about the surge of blood that is rushing into the arterial system during each contraction, each ventricular contraction, causing the elastic walls, basically, of your arteries to expand. Okay, so they expand when it contracts, and it stops, or kind of gets less as your pressure drops. So then you don't feel that pulse. the kind of the pause in between. Okay, so then your arteries are expanding and then they're recoiling, expanding and then recoiling with every beat. Okay, so this alternating expansion and recoiling of the arterial walls is what is your pulse. That's what you're feeling. Okay, and you need to know these 9 pulse points. You need to know them. You know, it's kind of best if you can find them most of the time, not always, on your body, but you know, I usually start from the head down. So your temporal one is here at the temple area. Okay, sometimes you can feel them. Sometimes you can kind of feel them on kids or even elderly patients where their thin's a little bit skin, or their skin is thin. I can't talk. Yeah, actually I can feel mine. I'm feeling mine right now. So see if you can find your temporal artery. Mine is probably bounding because I'm upset with my family today for not cooperating well. My poor puppy had his procedure yesterday and I'm trying to get help with watching him, and they all have their own agenda. Okay, so you have the temporal one. Your facial one. What? Let me see. Hold on 1 second. All right, so facial then is along your jaw area there, not the carotid. So above, like your lower jaw. If you look on page 390, actually in your A&P book, your big A&P book that you use for Nicole's class, you should be able to find it. It's on that page there. And then your carotid, that's one of your more common ones that you check during a code situation. That's the one along your neck. You should be able to feel that one. So see if you can take a second and feel that one. Your brachial then, your brachial is on the inside part of your elbow, or the bend of your elbow. So if you place a couple fingers, so you have your center of your, where your elbow bends, the crook of your elbow. If you put your fingers kind of to the, let's see, I have to try to find mine. Like I said, it should be high right now. That's a place that we actually have to draw blood gases from. So it's in the interior, like the more medial area, so closer to your body along that side there. And we're going to practice this when we go to lab. Yeah, actually mine's a little bit more medial. So mine's kind of in the middle, but it's more on the side of the inside of my body. And then your radial is the most common site that we draw blood gases from. That's the one in your wrist. Okay, and your radial and your ulnar are kind of are parallel to each other. So your radial is then on the outside, so it's below your thumb. Okay, see if you can find that. Your femoral then is in the groin, and that's actually the carotid they'll check, but then the femoral for sure. The femoral should be, if you have a carotid blood pressure, if you feel a pulse there rather, they say that your systolic, your top number should be at least 60. Your femoral then is in your groin, and for some people it's really hard to feel depending on their size, but it's definitely a place that the physician, a lot of times that's kind of where he will stand during a code. So he's just kind of standing there in the middle. It's a good viewpoint to see what's going on with everybody, giving orders what needs to be done next, and at the same time he's holding pressure there on that pulse to see if indeed there is a pulse, and watching the monitor at the same time to see if we have to restart compressions. Then your popliteal, that's kind of a hard one to feel for. You might, if you kind of mess around, you might be able to feel it's behind your knee. Okay, so that's your popliteal. And then your posterior tibial is on the back of your ankle. Okay, and again, that one's kind of hard to feel unless you've had a lot of practice. Your dorsal pedius, or your dorsal pedia, pedial rather, is on the top of your foot, kind of in the middle, kind of up from your second toe, I would say. You go up from your second toe, your big toe, then your second toe. You should be able to feel it there. You can feel it on the top of mine. So see if you can find your pulse points and memorize these 9 pulse points. Okay, I'm still recording. Good. Okay. All right. So now we're going to talk about shock. Okay. Oh, before I go on, just looking back at my notes again. So when so again, just kind of reviewing your pulse, and it's a superficial artery over sometimes over a bony area. It kind of gives us information such as rate, rhythm. Sometimes you can actually feel irregular rhythm, like a pause perhaps, or like kind of just like you feel a strong one and then you won't, and then you will, and then it's irregular. And then strength. I want you to know this because I believe there's a test question on this someplace. So a weak or a thready pulse would be a low pulse, like the blood pressure would be, it's not necessarily slow, it's just weak, you just don't really feel it. And then a bounding pulse, B-O-U-N-D-I-N-G, bounding would really mean like your blood pressure is high. Like some people, you can actually see their pulse, what do I want to say, the word, you can see it fluctuate kind of in just looking at their skin. You can kind of see it going, I don't know why I'm lost for words, but a bounding pulse, then you can actually visually see it pulsating. That's what I'm trying to say, it pulsates. Okay, and again, remembering your normal range, you know, 60 to 100 beats per minute. That's a normal heart rate. Less than 60 is, hopefully you remember from last time, bradycardic. Greater than 100 is tachycardic. And again, we need to make sure, you know, checking our patient to see if they're symptomatic. Okay. And then a Doppler, I think I mentioned this the other day. I either mentioned it with you because I actually, no, I haven't recorded a different lecture yet. Anyway, a Doppler then is the instrument. I'm starting a new class. I'm starting advanced patient assessment. I just started on Friday, so my mind's a little more all over the place than normal. So a Doppler then is basically an instrument that we use to kind of hear the pulse. It's a little probe-like thing. It's similar to like an ultrasound, but it is sound waves, and it's maybe like the size of a marker, I would say. They put like a little bit of jelly, so if we have to draw blood gas from the wrist or even from the brachial, and we can't really feel a pulse, but we know that they have a pulse, but it's just their blood pressure is low, we'll take the Doppler and you put a little bit of that jelly on it, and then you kind of move it around until you can hear this like whoosh, 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 whoosh. It's like a little swish sound. Okay, and then you try to zero in and make your poke if you have to draw blood gas. It makes them kind of challenging and fun. And of course, hopefully the patient's not awake to realize you're doing that to them. Okay, so types of shock. We're going to be talking about different types of shock. And we've got cardiogenic shock, hypovolemic, neurogenic, anaphylactic, and septic shock. Okay, so there'll be a slide here coming up on each one of those. So I'll talk a little bit more here in detail about each type of shock. So the cardiogenic shock basically results from any type of heart failure. Like you may get cardiogenic shock after you've had a severe MI. It can also be caused by a drug overdose or different infections like a myocarditis or endocarditis. So basically it just means that the heart itself is affected. It's no longer able to pump efficiently to the tissues. You do not have enough cardiac output, and it can come on really rapid. It can be very dangerous, and so we need to be able to treat it with getting the heart to start pumping effectively, restoring the blood supply to the heart. So an angioplasty, a balloon pump is a device that they actually put in. It's kind of like helps basically the heart pump. Sometimes patients after heart surgery will they're put on the bypass machine, and if they're not able to transition well, or they're having some type of ventricular failure, they'll put them on the balloon pump. And it's a ventricular assist device, basically, that you can set. They set it usually, they generally set up in the OR, and then they come back out with it. I would see it a fair amount at Lutheran, and it's kind of like a ratio. So like they'll set it like a 4-to-1 ratio. So every fourth beat it'll assist, and that, or every third beat. So the higher the ratio, so let's say, I guess maybe the lower the ratio would be the right word. So if they're like on a 2-to-1, that means the assist device is helping them every other beat. So as they get better, they wean them off of it, so that maybe they'll go down to a 3-to-1, or they'll go down to a 4-to-1. So then every fourth beat they get that assist. And I don't know, I want to say like a 4-to-1 might be one of the lower numbers, the lower amount of assist, and then they try to just turn it off, and then eventually they remove it. But it is invasive. So it needs to be, put in a sterile setting. Or, bypass surgery obviously would be a way to help reverse that. Alright, so moving on to hypovolemic shock. This is probably one of the more common ones you're going to see. Basically, you're losing loss of blood or fluid in the blood vessels. Okay, so you have decreased blood flow. Obviously, a hemorrhage would be a likely cause, but you just think if you have decreased blood flow, you're going to have decreased blood pressure, which is going to lead decreased blood, obviously, to the tissues. Okay, so one of the cause could be hemorrhaging, or just loss of interstitial fluid that causes basically the plasma part of the blood to kind of leak into the tissues. You also can get very dehydrated, and that's more so like in elderly patients, and actually really young patients and children and infants. They're more common they're more likely to become dehydrated from an illness, especially diarrhea. Diarrhea can really take the fluid out of you. So just, if you have young kids, or if you know somebody that's child has a fever along with diarrhea, you just really have to watch for dehydration. Vomiting, obviously, and burns, definitely, because they just weep so bad. Severe burns. So that's one cause of shock. Neurogenic is another cause of shock, and this one's kind of interesting, I think. This basically results from a widespread of the dilation of blood vessels caused by an imbalance in the autonomic or the sympathetic nervous system. So the vasomotor sensor that's responsible for maintaining your muscle tone in your blood vessel walls. So what happens is that the vessels dilate, and it causes a seep, basically. So the fluid starts to leak, and it reduces your blood pressure and obviously blood flow. Okay, so the blood vessels then dilate, relax. It also leads to pooling of the blood in the venous system, and then therefore you're not having sufficient enough cardiac output. This can happen if you have damage to the spinal cord or the medulla, okay, the medulla area of the brain, or certain types of drugs can actually cause neurogenic shock. It's kind of a scary one. And what's happening here with this person is they're wearing mast trousers, M-A-S-T. You can kind of look it up. I haven't seen mast trousers used for a long time. I remember seeing them in Wisconsin when I was first in RT, and what they basically are is like a huge blood pressure cuff that you put on like the lower extremities of the body to help push the blood back to the core, okay, back to the central organs, to get it back to the heart, get it back to the kidneys, get it back up to the brain and the lungs. Okay, so it kind of compresses those lower vessels, so they're called mast trousers. They're used in the military, I know, and I'm sure some, some ambulance crews definitely still use them, but I haven't seen them used for a long time. It would be like a severe trauma or something to like the lower extremities where you're really bleeding out. That's probably where you'd see it. Anaphylactic shock kind of acts a little bit like the neurogenic shock. Basically, it's an acute reaction, okay, allergic reaction, which is called anaphylaxis, which you've probably heard of, but you can actually go into anaphylaxis shock. It's the same type of thing. What happens is you have that blood vessel dilation that goes on. So if it's not treated, the anaphylaxis is not treated, you will go into anaphylactic shock with the widespread vessel dilation, decreased blood flow, decreased blood pressure, and airway restriction. Okay, so everything kind of becomes swollen, and then your airway constricts. Okay, so then we have to intubate these patients. So some of the common ones, as you can see there in the picture, eggs, bees, peanuts, strawberries, even shellfish, certain medications. So that is something you might deal with in the ER. And here's some different pictures of people that are in anaphylaxis. So it's generally treated with epinephrine. Obviously establishing an airway is important. So, all right, septic shock. This is definitely something that we see in our ICU. Okay, so we get septicemia, which is an infection of the bacteria, basically. Staph and strep are pretty common in the hospital. So these toxins then cause, again, the blood vessels to dilate, okay, which then leads to that shock where you're not able to maintain a blood pressure. So there's these toxins that are released from the result of the bacteria infections. Okay, and then toxic shock syndrome is part of a type of septic shock. So you've heard of that toxic shock syndrome. So some of the sources again of the sepsis, again, it's staph and strep, but depending on where it is, it can be a pneumonia, it can be a UTI, especially in elderly patients, because they're not sometimes as aware of the symptoms of a urinary tract infection, and they can get a UTI sepsis. Abdominal or digestive infections, if you have a bad gut, or thinking of maybe a gallbladder that burst, or an appendix that might rupture. Those types of things could cause a sepsis. An infarcted bowel, a bowel that's dead and it isn't caught, those types of things. So definitely see a lot of septic shock, and again, the big challenge is maintaining their blood pressure. Aspiration is another one that can cause sepsis, and we'll talk more about that too. All these things coming up. Alright, so here's just kind of like a little diagram there that basically is summarizing your different types of shock. One second, I'm just looking at more of my notes here. Okay, so you have the types of shock, and then the presentation. Okay, so in the middle column there is how they're going to look. Okay, so if they're hypovolemic, they're going to come in with a low blood pressure, their heart rate's high, okay, because they're trying to compensate for that low blood pressure, okay. They're trying to compensate for that low stroke volume, so the heart rate's going to speed up to maintain that cardiac output. They're going to have a weak, thready pulse. That thready pulse just meaning you can barely feel it. You might not feel it with every beat, it just might be occasional. They're going to be cool, kind of sometimes clammy, which is more like moist, cool, clammy, very pale. Their urine output is decreased. So obviously because of the low fluid levels, the hypovolemia, that's basically low fluid hypovolume. Their cardiac output is going to be down, and they're going to have an increased systemic vascular resistance because everything's going to try to constrict to get, to maintain that cardiac output. So cardiogenic, again, hypotension, tachycardia, weak thready pulse, pretty much everything the same. They could have a urine output of less than 30 mils per hour, and that is your minimum urine output that you want a patient to have, is 30 mils per hour. If they are not having 30 mils out per hour, they can definitely go into renal failure. Your kidneys are going to start to shut down. So some of that fluid then, because the heart's not pumping effectively, they're going to, when you listen to their lungs, they're going to have these crackle sounds. They actually kind of sound like Rice Krispies in milk. You can kind of hear the little crackle crackle. And we'll go over this more in patient assessment here coming up soon. Also, another way to kind of simulate crackles is to take a piece of your hair or a little grab of your hair and just kind of roll it between your thumb and your finger. Just kind of roll the hair, and you can just kind of hear that little sound. Those are crackles. But I have some DVD that we can listen to all the different sounds. And then again, a tachypnea, which means they're breathing fast. Okay. Again, decreased cardiac output, increased systemic vascular resistance. They're trying to maintain that cardiac output. Neurogenic, hypotension, they may have warm, dry skin. They're bradycardic, so their heart rate has dropped. They have decreased cardiac output, obviously. They have dilated, because that's part of that process. They've lost their sympathetic tone, so their venous and their arterial are dilating, and that's why they have no blood pressure. Okay, that's where they're going into shock. Shock basically means no blood pressure. For what reason? This is what we're looking at, why we're looking at our patients, trying to figure out what's going on, what is the cause. Okay. Anaphylaxis or anaphylactic shock. Again, they're hypotensive, tachycardic. They may have a cough because their throat is irritable, starting to swell up. They're dyspneic, meaning they're short of breath. They may have some redness going on, like hives. They could get restless because they're having a hard time breathing. They could, if their airway starts to swell, they can decrease level of consciousness, LOC. And then these patients actually, because of the dilation that's going on, because it's similar to the neurogenic shock, they will actually have a decreased SVR because everything's dilated out. Septic shock, again, same type of thing. They may have a bounding pulse, mainly because the fever, their skin might be warm, flushed, again, decreased urine output, and then because of that dilation, it's attributing to that bounding pulse, and again, a decreased SVR. I thought 23 slides wasn't going to take me that long, but apparently it is, but we'll try to move along here. So, though I think when I put you on pause a few times, I don't know if the timer still goes or not, but had some interruptions. Baroreceptor reflex. So again, these are those baroreceptors that I mentioned before that we see that can be found in the aortic arch, okay, or in the carotid artery, and in the carotid artery, not or, they're in both. And so these receptors are regulating the blood pressure. Okay, so it senses, they're like little internal monitors that are monitoring the blood pressure and help keeping it regulated. So they are based on the stretch receptors, meaning how much the vessels are being stretched. Okay, so that is based on, and you should hopefully remember this, the stretch receptors was that Frank Starling's law that we talked about back in science. Okay, so if you have an increased stretch, okay, so you have your rubber band, you have an increased stretch. So let's say in our vessel, our artery is stretched because we have volume in it. Okay, so that's going to lead to an increase in the force of contraction. Okay, So, you know, again, that rubber band, so we have increased stretch because we have increased volume. Let's say our vessel is made out of a big rubber band, a big huge tube-like rubber band, and we've increased it because we have more volume, and then we're going to have a increased force of contraction. It's going to snap back harder, and that is related to the preload, and we'll talk about preload more. We've talked about it a little bit, probably a couple presentations, PowerPoints ago. So that's related to preload. So the baroreceptors, again, are found in the wall of the aortic arch, and the impulses travel along the vagus nerve, and then again the carotid artery, where the impulses travel along the glossopharyngeal nerve. So you need to study all this good stuff. And just kind of giving you a picture, and I know you've seen this picture before. So again, we're talking about the baroreceptors here in the aortic arch, with the little yellow, how those ones are should be following the vagus nerve, and then the glossopharyngeal nerve along the carotid artery, and they send signals into the medulla of the brainstem. All right. So like if somebody's had a brain injury, like a trauma or something, or if they've had a stroke in that area of the brain, it can definitely influence their blood pressure. So if those parts of the brain are injured, so sometimes they'll like herniate. The blood pressure isn't being regulated, so they'll just kind of herniate their brainstem. So they'll just kind of sort of like get this big old bleed. So that's kind of why that's related, because you're thinking, well, why is the heart being affected when the head was injured? And that's why. All right, so looking at the different effects that the cardiac cycle has on the blood pressure. So the blood pressure rises and falls during a different pattern during your has a cyclic. So your blood pressure rises and falls in a pattern, like a wave, basically, in the phases of the cardiac cycle. Okay, so you think of your ventricles contracting, the blood then enters the pulmonary trunk and the aorta, and that's going to increase your arterial pressure. And then as the ventricles relax, and then atria are contracting, then that's when the blood enters the ventricles, and then your arterial pressure decreases. Okay, so it's kind of like this wave-like pattern. So be familiar with the pressures. On the next slide, you'll see from I think it should be the next slide on Desjardins. Okay, just kind of, this is on page. Wait, hold on. Get back. Page 233 in Desjardins, you'll see this diagram, and basically it's just, and I just want you to, I don't believe, I'm just looking really quick myself. Should I have this open? Yeah, it's 233 for sure. Know these pressures, just be familiar kind of with them. Like, okay, so the basic things I really want you to take away from this is that you'll see that the left-sided pressures are higher, right? Your left side is going to the body, okay? It's going to pump further, okay? So that's why your pressures are higher. So that's really kind of the big takeaway for right now, for all intents and purposes. We will be studying these more in depth in CV diagnostics, but you can just kind of see the pathway, how your blood is coming back to your left atrium, and then as you eject out of your left ventricle, then you get the blood pressure of eventually 120/80, textbook perfect. As it travels, it has a further distance to travel, so it's a higher pressure system. So it's your resistance system. And then again, your venous being your capacitance system, and or circulation system, whatever. Then you have lower pressures, a little bit higher pressures in the heart itself on the, well, that's more of the pulmonary artery going out. So you have to have a fair amount of pressure going out of the pulmonary artery to the getting into the lungs. But overall, that pressure is lower on that side. So these are mean intraluminal blood pressures at different points in the pulmonary and the systemic vascular system. Like I said, you will be required to know these normal values when we get into CV diagnostics. But just kind of be aware, left side of the heart has to work harder, right side is more of your pulmonary circulation, so the pressures are a little bit lower. Alright, so talking about pulmonary blood flow, and I'm sure you've been talking about this too with Derek, which reminds me, we'll talk about it on Thursday. Never mind. I was a little upset. He told me that some of you didn't remember actually maybe I will talk about it a little bit now. I'm going to talk about it in a couple slides here. I talk about Posey's law, because he was telling me at graduation on Friday that you guys, some of you didn't remember, like, to the fourth power, what that meant. Okay, so like if you have 2 to the 4th power, it doesn't mean 2 times 4. It means 2 times 2 times 2 times 2. Okay, so come on guys, help me out. Actually, that should have been stuff you should have learned like in middle school and high school. I know we forget, but you know, sometimes on the spot stuff, you know, we forget, but please try to remember that. Alright, so our pulmonary blood flow, things that affect the distribution of the pulmonary blood flow is gravity, cardiac output, and your pulmonary vascular resistance. Okay, so you think about how your blood flow is normally going to happen with gravity, so the distribution of the pulmonary blood flow. So if you're sitting upright, you're sitting up in the chair, okay, you think about it, your blood flow progressively decreases basically, okay, in the upright lung. So I'm just saying, from sitting upright, you're going to have more blood flow at the bottom of your lung and less at the top. Okay, I think this is worded kind of weird. Progressively decreases from the base to the apex. Yeah, so as you go backwards, okay, basically you go backwards from the bottom to the top, it progressively decreases, so you have the most at the bottom and it gets less and less and less and less as you go up. Okay, so thinking kind of backwards, I guess. Alright, so we're going to talk about each of these just for a minute. So gravity then. So gravity hopefully should make sense. So gravity is obviously pretty heavy. It's gravity dependent. Blood rather is pretty heavy. It is gravity dependent, okay? Because blood basically enters the lung at about midway in the chest. In order to pump blood to the apex or the top of the lung, the pulmonary artery pressure has to be greater than 15 centimeters of water pressure to actually overcome this gravity, okay? To overcome gravity. Because of this, most of the blood flows or falls into the lower 1/2 of the lungs. So I've got 2 different kind of notes here. Yeah, so the pulmonary artery enters at about the middle or the hilum, okay? So most of the blood falls to the lower half of the lung, and then you have to have that 15 centimeters of water pressure in the pulmonary artery to push that blood up to the apice, okay? So if you think of it, then the vessels, okay, at the base have increased pressure because you have more blood down there, okay? So things are being compressed more, so you have more blood, and so you have to have increased pressure to get the blood back up. And then the vessels at the apice, or the apex, the top, have lower pressure, okay? There's less blood there, plus of the gravity. Okay, so increased pressure then, and we're thinking about that increased pressure at the base because that's where all the blood is because of the gravity, okay? And there's more blood there, there's more volume there, you have more pressure, okay? This causes then the vessels to dilate, okay? So they widen, okay, because they have increased pressure. There's more pressure being put on the vessels at the base. So this is causing the vessels to dilate or widen, which then decreases the resistance to flow, okay? So it's easier for the blood to flow through them because you have a bigger tube, and that's part of that Poiseuille's law, all right? I want to make sure I wanted to change my slide yet. Hold on. Okay, yeah, I think I will change my slide because this is kind of where I wanted to talk about this too. All right. There we go. Okay. All right, so due to the gravitational effect on the blood flow, the intraluminal pressures of the vessels in the gravity-dependent areas, or the lower lung regions, are greater than the least gravity-dependent areas in the upper regions. Then again, this higher pressure in the vessels makes the vessels distend. Okay, so it pushes them out and they widen. And then that decreases the resistance and allows blood flow to increase. Okay, so again, so Poiseuille's law, this is basically Poiseuille's law in action. Okay, so when you think about, like, if you have a hose, okay, is one example. You have a hose with a bigger diameter, you're going to have more water flowing through it. Versus if you constrict the hose, you bend it or kink it off, you're not going to have any flow going through it. And another analogy is if you think about a milkshake. Okay, now I don't know, I remember as a kid the McDonald's straws. The McDonald's straws always seemed to be the best straws. They always seemed to, their diameter just seemed a little bit bigger around. I just remember that as a kid. I don't know if they are anymore. It doesn't seem like they are, but as a kid it seemed like they were always bigger around. They had big, wide straws. Okay, so you could really suck up that milkshake. Okay, so you had increased flow. Okay, now think about it. If you took out that straw and you put in one of those coffee stir straws, one of those little itty bitty ones, the white and red ones, the teeny tiny holes, your flow is going to be so much less. You're not going to be able to suck that. You're going to have a decreased flow. You're also going to have increased pressure in that area, so you're constricted. Okay, but it's also related to decreased flow. Okay, all right, try to grasp that concept. All right, I'm trying to think what slide I have coming up next because I wanted to talk about one more thing. Oh, okay. So before I go to the next slide, which is actually our last slide, thank goodness, because I'm almost at an hour now. So when we think about lung positions when we're trying to oxygenate patients, and I'm just want to just kind of plant these little seeds in your brain right now, so you kind of get used to sort of thinking this. And this is something that we're actually really seeing that's successful with the COVID patients. Patients are oxygenating better when they're laying on their tummy or they're prone. Okay, so the opposite of being prone is supine. So supine is lying on your back. Okay, so your gravity dependent area is your posterior lungs. So you have less blood in the anterior and less pressure, but more blood in the posterior, or more pressure. So on the prone side, when you're proning somebody or a stomach face down, okay, the gravity dependent area then is now switched to the anterior portion of the lung. Okay, so you're facing down and more blood flow then is going there, and more pressure is happening there because of the blood flow. And because of the way the hold on. Okay, so we're using this then to help treat patients that are in ARDS, acute respiratory distress syndrome, and that's what's happening with these COVID patients. They're going into ARDS. So The physiology behind it, physiological reason is still a little bit, they're kind of not really exactly sure like why it really works, but it has to do with the ventilation perfusion mismatch is decreased when people are on their tummy. Okay, so it helps improve oxygenation, it helps improve respiratory mechanics, it helps to homogenize the pleural pressure gradient and the alveolar inflation and the ventilation distribution. Okay, it also increases lung volume and helps reduce the amount of atelectatic regions, the areas that collapse. Also, they feel that it helps facilitate drainage of secretions, and to eventually our goal is to reduce ventilator associated lung injury. So it's just one of the different ways that we are finding that helps proning people when we ventilate them. But it just has to do kind of with the distribution of the ventilation and the oxygenation. So lastly, we have this little diagram to kind of look at, and this is the different zones of pulmonary circulation, and I'm quite certain Derek will be definitely going over this too. So you think about the apices or the apex area, top part of your lungs, least gravity dependent when you're sitting upright, worst for perfusion because the blood is not going there, but it's the best aeration. Okay, it's towards the top. The air has the larger airways on the top. Okay, so you think of your trachea and your main stem bronchi. They go at the path of least resistance. So your alveolar pressures, if you look at the different driving pressures on the diagram there, so your blood flow is the lowest, but your driving pressures, your alveolar pressure is greater than your arterial, which is then greater than your venous pressure. Okay, so your V meaning your veins. And then if you look at zone 2, which is your middle area, then that's kind of in between, middle, good perfusion, pretty good aeration. Okay, your arterial pressure there is greater than your alveolar pressure, which then is greater than your venous pressure. And then the base being your most gravity dependent, where you're obviously having your best perfusion based on gravity, so the blood is flowing to the bases. Worst aeration because everything is being compressed, you have your smaller airways down there. Okay, so again, these factors change based on lung positioning. Okay, so for example, the other thing to think about is if we have a patient that has a pneumothorax, okay, so part of their lung is collapsed. So we would like to position the person with their collapsed lung up, okay, so their bad lung is up, okay, so it's collapsed, it's not ventilating as well. So we want the area that ventilates well down. Okay, so we want the good lung down because that's where the best perfusion is. Okay, so then you have the best gas exchange happening. Okie dokie. I think that is going to do it for this reference on page 237 in Desjardins. There's a very similar diagram, and then hopefully the text can help explain. So as always, email me with questions and we'll talk soon.